This is chapter 5. It's called Syncope, and as I've said before, it's just another name for fainting. So this is your case scenario. Your next patient is due for 4 quads of SRP, or deep cleaning. His vitals are within normal limits, although slightly elevated. His medical history and dental history are non-contributory, except that he hasn't had dental care for 7 years. So you approach him with a topical anesthetic. You notice he's really nervous. He gets really pale. Little hairs on his arms stand up. And all of a sudden you notice he's lost consciousness. And it really can happen that quick. So what do you do? Let's find out what it is, and then we'll figure out what to do. So I bring this up because at the beginning of these chapters, you're going to see a case scenario on the first page, and then on the last page of the chapter you'll see a case resolution and conclusion of what they think about this and what happened. So they're good little case studies to look at, because a lot of these situations put this way, we really do see. So fainting, it's a sudden, transient, meaning it's just for a short time, it's not permanent. Sudden transient loss of consciousness and postural tone with a spontaneous recovery. So just a lot of fancy words to say that you lose consciousness for a very short time. And when you lose consciousness, you can, if you're standing up, you'll fall down. If you're in a chair, you'll go limp. If you're lying down, you'll go limp. So it's often caused by loss of brain oxygenation, which is cerebral, that's brain, and perfusion. Perfusion is blood flow. Often it's associated with a very stressful condition. I would know that. Common medical problems affecting all age groups. So children, pregnant mothers, and the elderly are especially susceptible. I would try to remember that. Syncope is a sign rather than a primary disease. So there were questions on boards talking about syncope being a disease. It's not, you wouldn't say they have the disease of fainting. And they fainted, they're fainting because of something else, probably. So the primary disease is something that you have to figure out, and the syncope is just a sign of that preliminary problem. So if the fainting or syncope lasts longer than a few minutes, it could be indicative of a more serious problem. The patient might go into a seizure if the fainting spell lasts for too long, because they should recover pretty quickly. If they don't, they could possibly, like I say, go into seizure, hypoglycemia, COPD, heart or renal issues. So in children and in the elderly, which are particularly susceptible to fainting, in kids it could be just because they missed a meal, or they're really dehydrated, or they're out in the heat too long and really dehydrated. If they cry too much, if they get into just a raging fit and start crying and can't stop, they can eventually make themselves faint. Exertional activity, like a child who's having a temper tantrum, if they clutch their fists real tight and hold their breath and just like this and make the veins on their neck pop out because they're so mad, they can cause themselves to faint. So the elderly will be postural changes if they're getting up from a seated position, or up from like a squatting position. Defecation, coughing, orthostatic hypotension, which is the postural changes. Medication, diseases, heart disease, diabetes, renal, which is kidney disease, insufficiency, and of course COPD. Most common medical emergency in the dental office, you already should know this, is syncope. It's 50% of all the emergencies is just syncope. So most syncopal episodes occur before, during, or after the administration of a local anesthetic. It's them being able to see it. I remember a student quite a few cohorts ago brought her boyfriend in, and he was a real looker. He was really young, and they'd been going together for a long time. Cute couple, and he was really good looking. But what I'm saying by that is he was kind of macho, like like a little tough man. So he's down in the chair, and she has to give him a deep cleaning, and he's fine about the whole thing. And she brings over the syringe. He takes one look at it out the corner of his eye, and he's out. He's out like a light. So he fainted, and he came to real quickly, and actually wanted to continue and finish the whole procedure, but it can happen. So the highest recurrence of syncope is within the first 24 hours of the initial event. So sometimes when our patients have a syncopal episode at the office, we may want to ask if we can get a driver to come down and drive them home, come back later for the car. The very first 24 hours, they can have another recurrence. It's the highest part of, if they're going to have a recurrence, it should be in that first 24 hours. So we don't want them to be driving down the highway and all of a sudden have a second episode. So here's the types of syncope. This is in your book. We have the most common type, which is down at the bottom. The most common type is the neurocardiac or vasodepressor syncope. And then we have, so that has to do with the heart, the nerves of the heart. And the second is at the top. It has to do with the heart, cardiac syncope. And then you have the types of syncope which are non-cardiac. They don't have anything to do with the heart. And the case that I just told you about, the young guy looking at the syringe and fainting, doesn't have anything to do with his heart. It was a situational occurrence. It was a stressful situation, and all of a sudden he was out. So let's look at the most common type. It's the neuro is nerves, cardiac is heart, and a vasodepressor. A vaso means blood vessel. So a depressor means if someone presses down or depresses one of your blood vessels, it's going to cut it off, right? And it'll constrict. So vasodepressor is just another name for a vasoconstrictor. So neurocardiac or vasodepressor, you have noxious stimuli, and you have activation of the sympathetic division of the autonomic nervous system, which we'll go over. Actually, I just told you the wrong thing. That noxious stimuli would be looking at the needle. That would be the noxious stimuli, not the situational occurrence. Noxious stimuli means that if you're looking at something that causes you fear, or that just gets you all upset, that causes you maybe to faint. Okay, so non-cardiac, let's look at that. They could be seizures. Seizures are due with maybe epilepsy, maybe having fainted too long, and you go into a seizure. That doesn't have anything to do, that particular one, with the heart. Orthostatic hypotension, you stand up or sit up too quickly. Situational occurrences we'll get into in a minute. Hyperventilation, you're breathing too fast. There's a complete lack of carbon dioxide. And metabolic diseases would be like diabetes, which don't have a direct effect on the heart. So those that would, the second most common would be those that do affect the heart, cardiac fainting. And the etiology could be rhythmic or obstructive. Something could be with the rhythm of your blood flow, and it is maybe your heartbeats, instead of going thump, 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 or something like that, they're going thump, 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 thump. Okay, so the rhythm is all off. It could be completely off. It could go be in a different pattern. It's anything other than absolutely normal. An obstructive could be a blood clot. So that's absolutely going to be from issues that have to do with the heart. So you have cardiac, non-cardiac, and neurocardiac. And neurocardiac is the most common type. So here's the situational. It's coughing. Older people can get this from urinating, defecation, neck stretching. They've been known to have some elderly faint. Hair grooming, venipuncture, puncturing the veins, penetrating with a needle, and even swallowing in a really weird way that cuts off the oxygen. So then we have what's called the Valsalva maneuver, and you'll need to know this. The Valsalva maneuver is a forced expiratory effort against a closed airway, like holding your breath. Sometimes people use this in an airplane to use in clearing their ears, and you'll hold your breath and hold it like and make yourself real tense, and it pops your ears. That's called the Valsalva maneuver, and this is sometimes what little kids do to get their way. They will decide that if they force this air out against a closed, or mouth is closed, and they keep forcing it out like they're holding their breath, that eventually they may faint, or the parent fears that they'll faint and lets them have their way. And hyperventilation, we've talked a little bit about it. It's excessive breathing causing change in chemical makeup of the blood. So what we talked about before is in breathing, there needs to be an even exchange of oxygenated air coming in, and then you're breathing out used air and carbon dioxide. There needs to be a way of transferring the air and the carbon dioxide. And when you have hyperventilation, you're breathing in so fast that it doesn't have time to release the carbon dioxide. And you could possibly faint from that. It can cause cerebral, which is brain, vasoconstriction, constriction of the blood vessels, which can lead to syncope. The neurocardiac syncope, which is nerves of the heart, it's the most common to dental offices. We have a vasodepressor, which is low blood pressure. It's also synonymous with vasovagal. Vasovagal and vasodepressor would be one and the same. You have a vagal nerve, and this vasovagal would be completely depressed. You have the nerves of the heart and neurally mediated. So associated with some type of noxious stimuli would be pain, fear, complete exhaustion, or a big illness. Noxious is another word for, it means harmful, poisonous, something that's very unpleasant would be noxious stimuli. So this neurocardiac, I wanted to wait till we got here to kind of go into that from that first slide. It's the activation of the autonomic nervous system. That's where you get your fight or flight response. So it's the sympathetic nervous system which is acting. So what happens in a dental office is that these people are confined to one position. They're either laying down or sitting, or a combination that keep going back and forth. So when they get really upset or nervous, they can have a fight or flight response. The sympathetic nervous system releases catecholamines, They release epinephrine, which is another name for adrenaline that we naturally make in our body, and norepinephrine, particularly to the muscle tissue. So it's trying to prepare your body for movement, and where it's pumping the blood back to the heart. So you get a fight or flight response that you want to do. You've got all this epinephrine and adrenaline, norepinephrine building up in your body, and and there's nowhere to go. So it pools. It will pool in your extremities so that your legs and your arms can flee if you need to flee a nervous or threatening situation, but it's not there. They're not fleeing. So it's taken blood away from like the head and trying to protect give the oxygen to your extremities. And if it pools there because you're not using it in your extremities, then it's going to make your head slightly a little less oxygenated, and it can cause you to faint. So that's the whole reasoning behind that. If no movement occurs, such as with dental patients, blood pools in extremities, causing a hypotensive response in the brain and in the heart. It'll slow the heart rate down, trying to compensate and decrease in the blood flow in the brain, and which between the two, like I just explained before, will lead to fainting. Signs, do you have any signs and symptoms of someone that's getting ready to faint? Sometimes you do, sometimes you don't. Sometimes they go through it so quick that you're not even noticing the pre-syncopal signs. So they could have pallor, they could have diaphoresis, which is sweating or perfusion, just little sweat beads on the forehead or something. They could have pupil dilation. Their pupils will get really wide. Excitation of the piloerector muscles, which are goosebumps, which the piloerector muscles that help the hairs on your arms stand on end, like with the goosebumps. Weakness, dizziness, vertigo, fear of heights, nausea, yawning, or sighing could be all signs all of a sudden of syncope. And these are signs that they shouldn't do on a normal basis. It's just all of a sudden it's escalating. And you can tell that if they have the signs that they may faint, and in fact, maybe they do. So what do we do? Treatment. If someone faints and they're unconscious, we're going to absolutely remove, of course, everything from the oral cavity. We're going to position supine with feet elevated above the head and heart, or the head below the feet and the heart. And it's called Trendelenburg position. I would know that. You want to also open the airway, assess circulation, loosen tight clothing. You may want to give oxygen, 4 to 6 liters per minute. You're going to continuously monitor their vital signs. We don't use ammonia inhalant anymore because it was bothering the septum and the tissues of the nose. However, when I was at a national boards 4-day event for students and educators, this was one of the questions, and they went ahead and flowed with it, that you do use ammonia inhalant now. And it was the correct answer. So on most of our books, it says not to use it anymore. You'll have to maybe do a little bit of research on that. And you usually recover really quickly. This is a prone position where the head is, that looks to me like the head is lower than slightly lower than the feet, and just a little lower if not on an equal basis with the heart. I would probably dip the top in just a little bit, not so much that it's going to eject somebody from the seat, which means lowering the head, but I probably would just step on the rheostat just very quickly and give it just another pop down. Let all the blood be rushing back to the head so that they can recover. With blood comes oxygen, and that's what he needs. So if they're unconscious and it stays that way, then you need to immediately call the EMS, or you're going to stay with the patient but have somebody else call the EMS. So the longer the patient is in syncope, the more likely a seizure will occur, and then you got something else to contend with. So once the consciousness does return, you're going to keep them in a supine, which means laying flat position until the patient feels well enough to be returned to upright position and the pulse returns to normal. Suspend treatment for the day. That's usually what they say to do, but in most offices in real time, we'll ask the patient, and a lot of times they want to continue the treatment as soon as their vitals return to normal. So emergency contact should escort the patient home as syncope can reoccur. If cardiac syncope is suspected, you want to contact the EMS, like we said, if you think it's really from the heart. And of course, you're always going to document any episode that they have, because if you don't document it, right, it didn't happen.